Hello, good afternoon, and welcome to this session of the challenges of cataract surgery in coexisting retinal diseases and comorbid conditions. To begin the session, let me welcome and call upon our chairman, Dr. Subhasish Nag, sir, to please come in front. Our esteemed panelists, Dr. Parag Mukhopadhyay and Dr. Parvez Alam, to please come over in front. To begin with, I'll first start with the cataract surgery in patients with diabetic macular edema. That's my topic. I'm going to present this. And then Dr. Aniruddha Maiti, and thereafter Dr. Rupak Biswas, and then Dr. Debashish Das will continue. So, huh? Okay. Uh, to begin with, let us discuss cataract surgery in patients with diabetic macular edema. We all know that cataract is an important cause of visual impairment in diabetics, and the incidence of cataract surgery in diabetics is about 2 to 5 times higher than a comparable non-diabetic population. Well, we are going to discuss the guidelines, the progression of DME after cataract surgery, management of DME after cataract surgery, and the effect of cataract surgery on DME in vitrectomized eyes. Any guideline can be followed. It could be the American Academy guidelines of preferred practice pattern, or it could be our own Indian guidelines, or it could be the ICO guideline or any other standard guideline. But we need to follow a particular guideline for treatment of diabetic retinopathy and diabetic macular edema, especially when we are treating a comorbid condition like this with cataract, when we plan for cataract surgery. Well, the principles of management, let us first look at a situation where there is a mild cataract. We need to carefully assess the diabetic retinopathy status, and we need to treat diabetic retinopathy or diabetic macular edema if it is there. Whenever the patient stabilizes, maybe 3 to 6 months later, we can plan a cataract surgery when the cataract is really mild. Now, in this kind of a situation where the cataract is moderate and we can see the fundus, we can assess the level of diabetic retinopathy or the presence of macular edema. In these kind of situations, where we can take a clear picture of the OCT, we need to attempt to treat any severe NPDR with or maybe PDR with lasers, or any DME with anti-VEGF, grid laser, or steroids before cataract surgery. But when the situation is like this, where there is very advanced cataract and we cannot really see the fundus, we need to do cataract surgery first, and then when the visibility, when the media is clear and we can assess and treat diabetic retinopathy and macular edema whenever it is after cataract surgery at the earliest. Well, the principles of management of DME, diabetic macular edema, is we need to consider anti-VEGF before surgery, at the time of surgery, or maybe after surgery when it's discovered, when the medium is cleared. As for the progression of DME after cataract surgery, we know that cataract surgery worsens macular edema and it hastens the progression of diabetic retinopathy. And the main cause of poor visual results after lens surgery were mainly the complications of proliferative diabetic retinopathy or macular edema, diabetic macular edema. It's crucial to know the risks of worsening of DME with cataract surgery. Like we know now that if the patient did not have DME or there was no history of treatment of DME, there is 0% chance of worsening of DME, obviously. But but patients with non-center involved DME had a 10% chance of worsening or developing central involving DME, and those who had pre-existing center involved DME had a 12% chance of worsening. But a history of treatment of DME put the patients at the greatest risk of worsening of DME, and that is about 20% of these patients have a chance of worsening of DME after cataract surgery. Now, the risk of macular edema has also been stratified, with in relation to the preoperative grades of retinopathy. The risk of DME in the first year postoperatively was 1%, even when there was no diabetic retinopathy previous to surgery. And the worst chance risk of diabetic macular edema was with severe non-proliferative diabetic retinopathy. When severe NPDR is present before cataract surgery, there are 13% chances of development of new macular edema. So these are the risks associated with the level of diabetic retinopathy. As for the management of DME after cataract surgery, we know there are many considerations. The preoperative considerations are that visibility, if it permits, we need to assess the level of diabetic retinopathy and the presence of DME. Treatment of diabetic retinopathy and DME needs to be done, and use of NSAIDs before surgery is very important. Well, as for the choice of the surgery, we all know that phacoemulsification is the choice of surgery, and we need to be careful about any meiosis, anterocapsular contraction. PCRs are more common. And as for the choice of the lens, we need to understand that a large optic hydrophobic IOL is the IOL of choice in these cases. We also have data to say that combined procedure has been shown to be safer and as an effective alternative to sequential surgery. By combined I mean vitrectomy as well as cataract surgery. Now, these are the publications which actually show that phacoemulsification is superior in these kind of cases. And of course, amongst the post-operative considerations, use of steroid and long-term use of NSAIDs. We use it for a longer period of time in these cases, and a regular follow-up with dilated fundus examination. As for the choice of anti-VEGFs, any of the anti-VEGFs are equally effective in this situation. And of course, the timing of surgery, timing of planning cataract surgery, like if a patient is already receiving monthly treatment for anti-VEGF treatment for diabetic macular edema and we have to plan a cataract surgery, then the best time is in between two injections, which is safe. Now, sometimes we have to differentiate between diabetic macular edema and a pseudophakic CME, and FFA is the tool to differentiate. Well, in vitrectomized eyes, we need to understand that previous vitrectomy does not appear to lessen the rates of post-cataract surgery macular edema. So we need to treat them as any other situation where macular edema can be expected after cataract surgery. To summarize, pre-existing diabetic macular edema prior to cataract surgery or history of previous treatment of diabetic macular edema may increase the chance of DME after cataract surgery. And assessment and treatment of DME prior to cataract surgery is extremely important. And treatment of diabetic macular edema with intravitreal anti-VEGF, steroids or lasers have all shown very promising results. Thank you. May I call upon Dr. Aniruddha Maiti to give his presentation, please. Yeah, please.
A very masterly simplified talk for everyone to understand.
Thank you.
But what is the time you would, in the preferred pattern after an injection, when you are giving it before the surgery? What would be the time difference?
Okay, at least a week.
At least a week.
Yeah, 7 days prior to surgery.
And then after 1 month again maybe.
Yeah, after 1 month. And if we really we are giving monthly injections in between, then in between is best, because we can really avoid the confusion of end of the reaction from the anti-VEGF or it's uveitis from cataract surgery. That differentiation can be made.
Another was, you said when you are doing it after, so you will get time to assess, I think.
Yes.
That can be done 1 month later.
1 month later. After that should be good. Yeah.
I think regarding the first one, nowadays what we do is give a Ozurdex injection before the cataract surgery, and within 3 weeks the cataract surgery is performed, and those cases actually do pretty well.
Yeah, because it has been shown that steroids and anti-VEGF should have equally good results, visual acuity in terms of visual acuity and also drying, macular drying. In fact, steroids would dry the macula faster or better, uh, and the visual acuity outcomes are the same with steroids and anti-VEGFs when we consider the pseudophakic patients only. So when we plan cataract surgery, they become pseudophakic. So it could be intraoperative, and if we want to give it before we can, Ozurdex or steroids are equally effective.
In our solitary practice, usually we do not declare, and even in institutional practice too, I think there is no declaration form to the patient that your retinal condition will deteriorate, worsen after the surgery. What should be the protocol actually if we go with the route?
Exactly. I think counseling is very important, and it should be made, very well, point very well made. Like patient, not only counsel. I think during our information to the patient also, or in the consent form also, we can add a line in this kind of cases that diabetic maculopathy as well as diabetic retinopathy can worsen after cataract surgery, and it has been documented. Thank you. Yeah.
Because there is a mild macular edema,
Yeah.
and in that cases, sometimes we prefer to give the anti-VEGF at the time of surgery, after the end of surgery.
Yeah.
So what you prefer? This is better, or you give first anti-VEGF, then wait for a week or 15 days, then you do the surgery.
Right. So if it can be done, if it is possible, it can be done separately, like preferably before surgery. Say,
I think 3 weeks before the surgery is the
3 weeks
ideal
before
time.
the surgery, it is very ideal. But it is not always that you can practice ideally. So even ICO guidelines say that during surgery you can give anti-VEGFs.
Yeah.
So that is absolutely okay with the guidelines permit that.
Thank you.
Thank you.
Just one point to add is here. By doing cataract surgery, we are not adding any VEGF load. So that is the most important.
Uncomplicated cataract surgery.
Uncomplicated cataract surgery.
Exactly.
So here you are inducing inflammation. And inflammation, if there is any existing macular edema, that is getting worsened, and that inflammatory material which can cause the relapse or the recurrence of the macular edema. So to prevent recurrence of the macular edema, we are supposed to give injection, which is preferably 2 to 3 weeks before, and then perform the cataract surgery. If there is no assessment of if you are not able to assess the macular edema status, then probably you can combine, and during combination you can see with the indirect ophthalmoscope, see the fundus, and then can plan it.
Thank you. May I invite Dr. Anuruddha?
Thank you, Dr. Ghosh, for giving me this opportunity. Well, I will be speaking on the preferred practice pattern in cataract with PDR. I will be speaking mostly the retina perspective. Already the DME part has been taken care by Dr. Ghosh. As we all know, the diabetic patients are 2 to 5 times more likely to develop cataract, and that too at an earlier age. And the significant number of the patient undergoing the cataract surgeries are diabetic. So what is important is early recognition and a treatment of the diabetic retinopathy before we go ahead with the cataract surgery, because that influences the final visual outcome. Now, we are going to discuss the various PDR conditions associated with the cataract, like a tractional retinal detachment, persistent vitreous hemorrhage, neovascular glaucoma. So, if we need to plan before the operation, this 5 scenario can come. First scenario is a cataract with PDR, high risk PDR. The bleeding has not yet started. The second scenario is a cataract with a vitreous hemorrhage. Still, we can see the retina. Third scenario is a cataract with tractional retinal detachment. And the fourth scenario is cataract with neovascular glaucoma. And the last scenario is a cataract with no visibility. DME has been excluded. So the first scenario is the cataract with PDR. We have to apply the pan-retinal photocoagulation. Now the point is whether we can see the retina or not. If the lens opacity precludes the preoperative PRP, what we can do is it can be administered as indirect PRP immediately after the operation or within a week after the cataract surgery. Uncomplicated phaco does not lead to diabetic retinopathy progression. If it does, it is mostly due to the poor glycemic control. As an example, the quiescent retina after PRP, out of the cataract surgery, recovered to 20/20 vision. Now, coming to the second scenario. The first scenario is pretty easy. You see, you do the laser, you can't see, you do the cataract and do the laser immediately. The second scenario is a cataract with a vitreous hemorrhage. First thing what we need to do, we need to rule out the tractional retinal detachment, because your plan for the operation changes if there is a tractional retinal detachment. If there is no tractional detachment, we can wait for some time. If that patient had some laser previously, then we can wait for some time, obviously. And if it is not lasered, at least we can plan it in a 3 weeks time. But in a tractional detachment, we have to operate as quickly as possible. So combine cataract and vitrectomy surgery with endolaser. Now, the presence of the pre-existing PRP scars are actually associated with better outcome when we deal with PPV for vitreous hemorrhage. Now, the intravitreal anti-VEGF results in a rapid regression of the retinal neovascularization, as we all know, and it happens very fast, as early as 24 hours. So there is a practice in a vitreous hemorrhage, people give anti-VEGF injection, but there is a head-to-head trial in the protocol N, which actually compared with the intravitreal anti-VEGF versus saline in vitreous hemorrhage, but there was no significant difference. So at present, only the preoperative adjuvant has been given in PPV. If we plan for a vitreous hemorrhage with TRD with a florid fibrovascular proliferation, so 3 to 4 days before we give an anti-VEGF. But just for the vitreous hemorrhage, yes, the new trials are coming like protocol S, but still the common practice is to do a very good laser. In spite of that, if there is some oozing in between, so we combine the laser along with an anti-VEGF. Now, as far as the surgical pearls for this this type of condition is concerned, we need to be very cautious in lifting up the posterior highlight. It's almost 100 times more adhered. We need to take care of the intraoperative bleed by elevating the infusion pressure and endocauterization. What is very important is, with a wide field visual system, it is very easy to do the laser up to the aura, because we need to prevent the rebleeding, which happens very frequently in a diabetic patient. And when the cataract limits the visualization of posterior segment, to spare the patient for the second surgery, a combined surgery will be better. But rendering eyes with severe NPDS, pseudophakia and aphakia actually increases the risk for NVG and NVI. This should be kept in mind, and the patient should be counseled that this is a possibility. So coming to the third condition, that is a cataract with a that's TRD. It can be an extrafoveal or it can be involving the fovea, because the management will differ whether it's an extrafoveal or it is involving the fovea. As we all know, this TRD stays for greater than 6 months. It is associated with the photoreceptor damage. The broader areas of adhesion, there is a chances of the membrane reproliferation. So the vitreous should be dissected as far as possible in the periphery as well. Yes, for the extramacular TRD, we can observe for some time and see whether it's progressing in the posterior pole. If it does, then we need to take the call of surgery. Silicon oil has been seen in various studies. It actually decreases the incidence of recurrent bleeding. So in complicated cases, in the complex TRD cases, at times we need to give the silicon oil. And obviously with the recent advances like viscodissection, curved scissors, segmentation, delamination, the most important is a viewing system. We can give preferably good surgical outcome in these patients, and the timing is very important. This is a combined RD which improved from finger counting 4 feet to 636. Now coming to the fourth scenario, that is a cataract with NVI. Not a very good condition. It needs a prompt treatment with PRP, induces regression of the new vessels before the cataract surgery. Yes, there is a dramatic short-term regression of the neovascularization with the intercameral or intravitreal anti-VEGF, and the phaco with without TRAB and vitrectomy should be considered earliest once the NVI regresses after this anti-VEGF injection. However, this visual outcome following the phaco in eyes with the NVGs are usually poor. So, to conclude, the number of patients with diabetes is increasing. The diabetic patients with a visually significant cataract pose a unique challenges during the surgery. However, as Dr. Mukherjee was mentioning, this counseling part is very important. We need to educate the patient before the surgery. But however, with careful pre-treatment of the diabetic retinopathy and minimally invasive surgical techniques, the visual recovery is quite possible in the most of the cases. Thank you.
Yeah, please.
As looking to the problem, once the cataract is more advanced, so many things we cannot detect in the posterior segment. So, as we recommend our diabetic patients, if the vision is almost hampered 50% or 60%, so it is better to go for early cataract surgery, because ultimately it has to be operated, if not today or after 6 months, after 1 year. So that time, at least the posterior segment is very well visualized, and accordingly we can treat if it is complicated later on also. So what is your suggestion for cataract surgery?
Absolutely. I think when we can't treat the posterior segment, we have to remove the cataract and then deal with the posterior segment as quickly as possible. So whenever this is the scenario, we need to deal with the cataract first and then the posterior segment evaluation.
Thank you.
There is a very common practice of giving blindly anti-VEGF to address the posterior segment and then do the cataract. I think that it is better to avoid it, because if there is a tractional detachment, then it will worsen.
Dr. Maiti, what is your take on the type of lens? Because nowadays, with the prevalence of demand for correction of presbyopia, would you recommend any premium lens?
I think there is a lot of controversy, like using a multifocal lenses in a diabetic in a retina. Diabetic eye, actually. So there is no absolute contraindication we cannot give. We have operated with the multifocal IOL. It is pretty much possible, but if given a choice, the monofocal lenses will be preferable, because sometimes in the periphery it becomes difficult, but with a newer viewing system it is possible. We can operate monofocal lenses. Multifocal, the rings causes refraction. In the periphery, it is difficult to operate at times.
Yeah, it is preferred that monofocal, not even aspheric.
Monofocal.
And non-aspheric monofocal lens is best in PDRs, because you never know. EDOF may cause a lot of aberrations.
Another contraindication, I don't know how. Is there any lens now made up of silicon material? Those lenses should be avoided. Nowadays, it's not available. Yeah.
In continuation of Sir's query, what I feel that without considering other problems, basically when patient is unable to see and when we are unable to see the patient's fundus, that is the time for surgery. Till we can see the patient's fundus and patient doesn't complain anything, cataract may be there, that is not the time, because it worsens. So
many times the patient, when they develop the vitreous stage, the surgeon told us, sir, you do the first cataract, then I will do the vitrectomy. So to avoid that position, if it is 50% or more than that, if it is mature, so better to get rid of cataract.
And the combined surgery is another other option. The patient can be spared from the second surgery.
Thank you. That was excellent. Let us move on to our next speaker, Dr. Rupak Kandivishwas, and he's going to talk about phaco in vitrectomized eyes.
Thank you, Dr. Ghosh, for inviting me into this session. Then phacoemulsification, you are not doing phacoemulsification, you are not doing anything extra in that. What is here lies how the situation is different from a normal cataract, a normal cataract patient. So that's what we need to be more precise about this talk. So doing cataract surgery, probably I will come to that part also, so how it is little different. But again, most important is that I don't have any financial disclosure regarding this topic. So the points to remember is that here there is no vitreous support. there is always a zonular weakness. And before that, let me tell you, if you are the vitreous, you are the VR surgeon and the cataract surgeon. So if the previous surgery is done by yourself, so you know that what has been done earlier also, so you are much more confident about the situation. So if it is not there, then probably you need to get the detail of it. So there is always a possibility of multiple manipulation and leading to the zonular weakness. These two combinedly leads to a situation which is high myope-like condition, because the AC goes down during this period. So, and we need to address the posterocapsular status, the retinal status, presence of silicone oil is there or not, and the biometry setting accordingly. So these are the basic point. If we remember that we need to go for these, then it becomes much easier. Then again, let us go back to the point of history taking. So first thing is that how long back was this cataract surgery was done. So on an average, in an uncomplicated phakic eye vitrectomy, so around an year is a common time when usually it starts. Average time is 1 year later. But if you see, the cataract has developed much faster or much earlier, and the cataract progression is much faster and becomes like white cataract. So probably there is always a disturbance in the lens capsule. So that's why it has progressed faster. So what was the exact surgery was done earlier, whether it is a vitrectomy with endolaser or a epiretinal membrane handling, or a silicone oil was given, or silicone oil is removed. So then immediate post VR surgery, before development of cataract surgery, what was vision? If it is documented there, then it gives you a kind of an information for the counseling of the patient. Post cataract surgery, what is the visual prognosis, and any lens touch history, if you can document it off, or silicone oil used or it has been removed. So these are the history precisely we should take before planning for the surgery. Points for the clinical examination, again, it's everything is like a normal routine what we do in a slit lamp examination, corneal status, AC depth. But here it is of even more important, because with this you can visualize much more grave situations, so that you can be prepared during your cataract surgery. The pupillary dilatation, zonular status, and posterocapsular integrity. So these are the things we should start seeing in slit lamp examination. Again, continuation of that, the density of the cataract, whether it is a centrally nucleus sclerosis, which usually develops over a period of time. The most common type is though posterocapsular cataract, but type of cataract, whether it is a totally intumescent cataract, so that also gives you, and whether there is any presence of phacodonesis. So these are give you much more of information about planning. Regarding ophthalmic investigation, ultrasonography, when the visualization is not proper, posterior segment visualization, then ultrasonography gives you good information. But if there is significant if there is silicone oil, then that has to be addressed properly. Ultrasound biomicroscopy can give you an idea about the zonular status and biometry according to the session, according to the situation. If there is silicone oil, so that mode should be different, or if it is due to, or it is dense cataract, then probably optical biometry cannot be possible, so ultrasound biometry has to be used for that. So for the prognostication, again, here is most important is that lens status, or accordingly the IOL related prognostication. So whether you will be able to put IOL or not in an intumescent cataract, in a vitrectomized eye, there is always a chance of runaway rhexis. So these are the situation we should, as Dr. Mukherjee was telling, so precisely prognostication of that particular case is very, very important, and that should be topped up with the previous retinal status, how it was pre-cataract development. And by this, if you have a little extended chat time to explain to the patient that this is the situation, I think that becomes much more easier for us to overcome the situation. And whenever is possible, if a written consent is available, then we can do it. Thank you. Thank you so much.
I think that was great. You bridged the gap for a phaco surgeon who is facing such a situation. I have one thing to understand. What are the nuances of a cataract surgeon like me? What different procedure would I take if it is a silicone, with silicone and without silicone oil eye?
I mean, you are talking about in presence of silicone oil.
In presence of silicone, what is the...
Yeah, that's exactly. I was just showing, if I can explain with this video slowly. So this is a video which is showing you can use either of the eyes to do according to the presence of it. So the presence of silicone oil, when you combinedly, I'll just stop it here. When you plan for combined surgery, silicone oil removal and cataract, so it is better to do the cataract surgery first and then to do silicone oil removal, because you are always getting a good amount of the support and cushion over which you can do the phacoemulsification very properly. But yes, again, you need to remember here, there can be always a zonular weakness through which the oil bubble can come up the AC and can cause sometimes, cause hindrance. In that situation, ample use of viscoelastic and taking that silicone oil bubble and again redo the surgery. And always in a vitrectomized eye, with or without presence of silicone oil, the low parameter phacoemulsification is what exactly we should look for. Slow phaco, what we do it.
Exactly. And preoperatively, the biometry, with silicone or without silicone oil, the viscosity of the silicone oil needs to be fed into the biometer so that we get a adequate, biometry done. That was excellent, Dr. Rupa. If we don't have any more questions, I think we'll request Dr. Devasish Das to go ahead with his presentation, and he is going to teach us about the pearls on uveitic cataract.
Can I have the laser pointer, please? Good afternoon, ladies and gentlemen. I thank Dr. Siddhartha Ghosh for allowing me here to speak on the pearls on the uveitic cataract. Basically, it's a tango. Tango is an Argentinian dance where the gentleman draws in the lady. So it's uveitis. It's a tango dance. The uveitis draws in the cataract. So that's how it happens. How do I? So the uveitis draws in the lens into the cataract formation, just like a tango dance. It happens, and thereafter, ever after, during the management, you have to keep on this tango dance. So why does this happen? This tango. The prolonged breakdown of the blood retinal barriers causes entry of these plasma phospholipids, causing increase in the lens epithelial permeability, causing cataract formation. Along with that, there is a 5-phospholipase A activity. There are steroids we use for the uveitis. Moreover, it further leads into development of secondary glaucoma and posterior synechia, which does cause cataract formation. Cataracts are frequently associated with HLA-B27, with or without the systemic disease present or not, and more with the recurrence of the disease. In Fuchs, you universally get a posterior subcapsular cataract. In JIA-associated uveitis, almost 1/3 of the cases develop cataracts, and we fear of complications, and we think twice, IOL or no IOL. In intermediate uveitis and pars planitis, the visually significant cataract develops in 10 to 50% of these cases. However, in sarcoid, the incidence is variable. In posterior uveitis, in cases of chronic and recurrent uveitis, their cataracts can develop because of the more exposure to the toxins. The Tango 1. In cases of small pupil in uveitis, usually suggest to do an optos, which is a wide field fundus photography, to check what's happening in the retina before we go ahead with the surgery. In selective situations, we should do an OCT to find out what's happening on the macula, treat it, resolve it, and then you post it for the cataract surgery. Control the inflammation, systemic suboptimal steroids preoperatively, and titrate it postoperatively, 2 to 3 months of inflammation-free period. However, in nowadays, we do encourage preoperative subtenons 72 hours ahead of surgery. Continue with the immunomodulation therapy and the biologicals if the patient is already on such medications. Ozurdex you can give in selective situations.
Antivirals is a must if it is a viral etiology uveitis. However, ATT and antitoxoplasma medications during the cataract surgery is not mandatory. Please remember, if underlying systemic diseases, systemic steroid coverage is always preferable. Preoperative steroid coverage and mandatory inflammation period is mandatory in JIA, the longer the better, in VKH, sympathetic ophthalmia in pan-uveitis cases, in HLA B27 anterior uveitis, and in intermediate uveitis, both in the recurrent and aggressive stages. And however, it is not so mandatory in the old healed non-recurrent uveitis, and you can even go without steroid cover in Fuchs uveitis. In these situations, do not delay surgery in lens-induced uveitis, in associated glaucoma where the IOP is very high, in the retinal detachment situations where the RD is requiring a surgery, and total intumescent cataract is, however, a relative emergency. In cases of infections like ARN, where there is no view of the fundus, we have to go ahead with the surgery. And these visualizations and managing the posterior segment pathologies are a priority. Go ahead with an early surgery. How do we assess preoperatively? We should have adequate control of the inflammations. The AC cells and flare should be minimum, vitreous activity minimum or nil. However, the prognosis like the corneal opacity formation, the CME formation, macular scarring, optic atrophy, hypotony should be clearly explained to the patient. We should also anticipate and explain priorhand the postoperative complications which can happen in these situations. How do we prepare the postoperatively? The eye must be quiet for 8 to 12 weeks. We should put the patient under steroid cover, usually 0.75 milligrams per kg of body weight, 2 to 4 days ahead of surgery. Nowadays, we usually give a posterior subtenons 0.5 ml in the subconjunctival space, and in cases of immunosuppressive therapy, in therapeutic dose hike can be done. However, that hike should be done 3 weeks prior to the surgery. In cases of viral uveitis or keratoid uveitis, systemic antiviral full dose 1 week prior to the surgery should be given. IOP should be controlled before the cataract surgery, either medically or surgically. And as far as the anti-glaucoma medications are concerned, we should avoid prostaglandin analogs. The minimal or no CME at the time of surgery in eyes with a history of CME, dexamethasone implants can be combined for these situations. Ultrasonography to be done when there is no view of the fundus. UBM is to be done when there is a pars plana or a ocular hypertony. Accordingly, the surgical plan needs to be modified. So the Tango 3 is interpretively we should take up the pupillary situation, the capsule and the IOL in these situations. What techniques should we follow? In non-dilating pupils, in case we should do a mechanical synechiolisis for the posterior synechial formation. Fibrotic pupils and seclusive pupil, we can undergo a pupillary dilating devices, and we can do a viscodilation if there is no adhesion. For the capsulorhexis, capsular staining can be done in cases of total haze. Calcified and fibrotic capsules needs to be cut with scissors, and friable capsules can be combined with OVD and microrhexis forceps. In cases of the incisions, preferably is the clear cornea, particularly in glaucomatous eyes where you're keeping the preserving the conjunctiva for future surgeries, and scleritis with thinning, again we need a clear corneal incisions. However, scleral tunnel can be done in eyes with immunomodulatory therapy to reduce the risk of infections. As far as the nuclear management, the direct chopping technique to reduce the zonular stress, cortical wash should be very thorough. The intraocular lenses should be in the bag only. Acrylic hydrophobic is the preferred choice. Clear lens preferred. Aspheric is fine. Monofocal plus is fine. Premium IOLs very cautious because the expectations may be high, the results may be poor. Particularly single page in the sulcus is a no situation in these situations. PC IOL positioning should be best in the bag. In the sulcus, if we put it in the sulcus, there is a risk of IOL-induced uveitis in these situations. Decision of the IOL or no IOL, particularly in the JIA cases, because these cases there is fibrosis, secondary lateral membrane IOL capture causing amblyopia in children. Initially, IOL was thought to be a contraindicated, But nowadays, IOL is preferred, but we need to select it specifically for the age of the patient, the posterior synechia formation, severity, and the preoperative intraocular pressure. Intraoperatively, we can put Ozurdex in selective situations like intermediate uveitis. However, systemic contraindications for oral steroids, uncontrolled diabetes, pregnancy, CME with significant cataract formations. Peripheral iridectomy is not mandatory routinely when the IOL is in the bag and there is minimal handling of the iris. However, it is a must when it is a risk of glaucoma in shallow eyes, significant pigment dispersion. IOL in the sulcus is usually avoided. I'll show you a few uveitis related cataract surgical presentations from Dr. Ayon Mohantas. I'll be specific to the uveitis part of it. This is how we prepare the 4 ports for putting the iris hooks and expansion of the pupils. It is after the first hook is put diagonally opposite, you put the second one, and then you go ahead with the other meridian. And the rest of the procedure remains the same. I'm skipping the rest of the video. In Malugin ring, again, after the primary formation, you put in the ring. You see to it that all the 4 edges are tucked with the iris and you get a proper dilatation for the surgery. Again, for the rest of the procedure, it remains the same. In case of a membrane mimicking, you try to detach the posterior adhesions of the iris from the membrane itself and the membrane from the cataract itself, and gradually by slow entwining movements, 1 quadrant at a time, you are completing the membrane removal from the pupillary axis. And if it is not at all moving, you can take it out and snip it off, the rest of the procedure again remaining the same. In case of membranectomy, where there is almost 360-degree adhesion, catch hold of the fibrotic membrane, 360-degree movement, and the membrane is out. This is the manual dilatation of the pupil in this case because the adhesions are not much, and again the rest of the procedure remaining the same. In case of posterior synechiolisis, you prepare the ports and then you dissect the adhesions from the lens capsule. These are all surgeries from Dr. Ayon Mohanta in these uveitis cases. The rest remaining the same. So basically it's not over till it's over post-operatively. So this was a 16-year-old male with a total cataract with a occlusio pupillae on immunomodulatory treatment and steroids, underwent the cataract surgery. But there was a dense aqueous haze in the first post-op day. It increased to fibrin formation around the pupillary margin and over the lens over the next few days. So basically, we need to monitor the IOP and the inflammations. We need to titrate the post-operative steroids and individualize each eye during the course of this post-operative period. Continue with the immunomodulatory treatment or the biologicals if the patient is already on such medications. Look for and beware of the post-operative fibrin, the IOL position. Apart from the PCO, there can be membranes, there can be cortical matters. So look for the CME, look for reactivation of the primary uveitis and many other surprises. For the postoperative follow-up, close follow-up for inflammation is needed. Frequent instillation of topicals, intensive corticosteroid therapy may be needed, and taper done down the line. A cycloplegic should be added, and topical NSAIDs. Systemic corticosteroids should be maintained at a preoperative level for 1 week and then tapered gradually 5 milligrams per day per week gradually over time. In cases of JRA, the poor visual outcome after ocular surgery in children seems to be associated with a more severe preoperative intraocular inflammations, development of complicated cataracts with loss of visual function at an early stage. The cataract hampered the visual function of the affected eye for a longer period of the surgery, and in all unilateral, bilateral, unequal cases, pre-existing amblyopia. So in case of a patient presenting with low IOP and cyclitic membranes developing, we should plan for a lensectomy vitrectomy and release these cyclitic membranes instead of doing only phaco. The complications can be various. There can be postoperative inflammations, CME, hypotony, or a spike, either way, posterior synechia, capsular fibrosis, anterior IOL deposits or a PCO, spontaneous IOL dislocation, ERM formation, risk of infections, and RD. So the take-home message is, for preoperative inflammation-free period and perioperative steroid cover is a must in these situations. Ozurdex can be used in selected situations. Pupil and capsular management is crucial. Adequate and complete rexes should be done. We should individualize each case and use expanders or non-traumatic expansions. IOL should be in the bag for the best of results. Hydrophobic acrylic is usually used. Preferably avoid premium IOLs in the eye. Postoperative follow-up and continuous management of primary uveitic entity is the long-term goal. Thank you. With that, I encourage everyone. The counter is closed at the AIOC here, but it's available. We can always take the advantage. It is extended till May for the registration of the AIOC 2024. Thank you so much.
Thank you, Dr. Das. That was excellent. You had a sort of master class within, though a little crossover of time was there, but we have enough time. If there are any questions in the house? Anybody?
I request Dr. Shah to guide us a little bit nearer to your subject. What are the guidelines to for a prior surgical guidelines before the operation with a pseudoexfoliation? Pseudoexfoliation.
Pseudoexfoliation, we should keep our fingers crossed, particularly to note that there is a zonular weakening, and at any point of time there can be a zonular dialysis. So basically we should always keep a CTR handy in the OT in these pseudoexfoliation cases. Preferably before you go for the surgery, dilate the patient fully and check for any subluxation, lens dislocations, or lens movements, phacotonesis, iridodonesis. In pseudoexfoliations, if the zonulars are weak, then you will have a tendency to have a phacotonesis or a iridodonesis. On slit lamp examination itself, you can plan the surgery. Once inside in the surgery, try to do a larger rexis such that there is a less strength on the zonules, which is already weak, and if there is no complications, you can put the IOL in the bag. If there are complications, then you have to plan accordingly.
Any preoperative NSAID?
For the dilatation purpose, yes.
Inflammation purpose?
Your dilatation, it maintains the dilatation.
Purpose?
Inflammation, if you really want inflammation purpose, then you need to give a steroid 72 hours before subconjunctival. NSAIDs doesn't do much of inflammation control.
Okay, thank you.
So next, you're going to read out
Actually, Dr. Krishnendu Nandi has to rush back to Calcutta. His mother is not doing well. So he has given the slides. If you allow me, I can present the slides. Yeah, correct. So he had the topic of peripheral retinal surprises in cataract surgery. So the risk factors, the incidence of RD with the types of cataract surgery, this was noted with from the different literature studies. ICCE had a percentage of 2 to 5% RD, ECC 0 to 3.6, FACO still less, 0.8 to 1.3. But when there is a vitreous loss, the RD percentage goes up by 20%. In post-YAG, within the first year, it's 0.8. Within the second year, it's 1.2. Peripheral retinal degenerations, the most common is the lattice degeneration. There are degeneratives, so retinoschisis, cystic retinal tufts, and zonular traction tufts. So I'd like to highlight a few cases where what we encounter in our clinics on a regular basis and sort out the dilemma we sometimes have whether to undergo cataract in these situations. Say the patient has come in for cataract surgery, 57-year-old female, myopic, -6 and -6 in both the eyes, BCVA 618. On indirect ophthalmoscopy, you are getting multiple lattice degenerations. No symptoms. Patient wants cataract surgery. Do you go ahead? This is a situation. I'll go over to the case 2. 37-year-old male, myopic, -12, both eyes, BCVA 624. Symptoms, patient complains of flashing. There is no family history of RD. IO, multiple lattice degeneration with an HST. You can see the fundus picture. So patient wants cataract surgery. Shall I go ahead straight away? Situation 3. 62-year-old male came for a routine checkup. On examination, myopia, -1 diopters, BCVA 612. IO shows single lattice in the superior temporal quadrant in both the with atrophic holes present. Patient wants cataract surgery. Shall I go ahead? Case 4. 67-year-old male, myopic, -5, left eye lost due to surgery, RD surgery. Symptoms are dimness of vision due to cataract. Indirect ophthalmoscopy shows lattice degeneration with holes. This patient needs cataract surgery. Can we go ahead? Fifth one, 76-year-old male, cataract, IO, retinoschisis in the periphery. Shall we go ahead with the cataract surgery? So basically, let us come down to all the points together. There is no evidence that eyes with lattice degeneration with or without holes are likely to develop RD in the future. 80% of the regmatogenous RDs are not associated with lattices, number 1. Number 2, risk of regmatogenous RD in an eye with lattice is only 1.4%. So there is no scientific evidence to suggest that prophylactic laser of the lattice in phakic and non-fellow eyes is beneficial. Even laser failed to prevent the regmatogenous RD in 2.9% of these treated eyes, and no scientific evidence to suggest that prophylactic laser of the lattice before the refractive surgery is beneficial. Folk and colleagues studied 388 patients with lattice in one eye and RD with lattice in another eye for 7 years, of which 151 patients watched, 164 treated fully, and 73 patients partially treated. So there is total 388, 151 was kept on watch, 164 full treatment, 73 partially treated. So of these 151 watched, 5.9% developed RD, 164 fully treated, again 1.8% developed RD, and 73 partially treated, 6.8% developed RD. So this is where we stand. So basically, we should understand the indications. The fellow phakic eye with lattice less than 6 diopters, and in fellow eye before and after refractive surgery. So there has been studies, progression to RRD, prophylactic treatment of retinal breaks. Asymptomatic retinal breaks develops in 13% of the cases, and symptomatic retinal breaks develops in 35 to 47% of the cases. So incidence of regmatogenous retinal detachment despite prophylactic treatment is 2.1 to 8.8%. In another study, it has been shown that 36.3% of eyes had regmatogenous retinal detachment despite prior laser prophylaxis. An interval of the regmatogenous retinal detachment after laser prophylaxis is usually even 1 week to 10 years. So it can happen at any point of time, irrespective of your laser treatment. So how do we implicate in our practice? Inherited vitreoretinal diseases such as Stickler syndrome, usually we prefer 360-degree prophylactic treatment. The choice of treatment is 360-degree encircling scleral buckling treatments, cryotherapy, and laser photocoagulation. Prevalence of retinal detachment in treated versus untreated eyes is 2.4% in the treated eyes and 24.1% in the untreated eyes. So laser photocoagulation in the fundal coloboma sparing fovea, prevalence of retinal detachment in the treated eyes is 0.6% only. So in the perspective journal, the peripheral retinal degeneration and the risk of retinal detachment, it was written that the evidence available suggests that most of the peripheral retinal degeneration should not be treated except in rare high-risk situations. It's an American Journal of Ophthalmology. So the treatment recommendations by AAO for HST: always dialysis, always operculum tear, sometimes atrophic holes, rarely lattice, rarely. So the take-home message is lattice in the fellow eye of a patient with RD. Lattice is in a symptomatic patient with a family history of RD, symptomatic retinal break, subclinical retinal detachment, and prior to refractive surgery in sometimes situations, we can do a laser treatment. Thank you.
Thank you.
Thank you.
And that's all for this session.
Yeah.
So that's very useful to all of us.
Subhasish,
Yes.
আমরা কিছু hyaluronic acid coated lens. We used to get hyaluronic acid coated lenses.
Yes.
And some euro lenses also with similar coating.
Correct.
And we used to use in SICs with uveitis
Correct.
cases. These lenses are not available.
Now it is not available, sir, because of the not so much of a demand but from the doctors. So these lenses are withdrawn.
So if someone want PMMA lenses,
There is a high propensity of deposition of iris pigments post-operatively if the inflammation is persisting. So you will get clumps, initially white clumps, and then they gradually turn brown in post-operative situations because the inflammatory cells get plugged onto these IOL surfaces. Thank you. Thank you so much. Thank you.